Welcome, everyone. Today we're diving into an explainer that completely deconstructs a wildly complex post-COVID clinical presentation. We're going to move way past those conventional silos and look at a truly integrated upstream-first failure model. If you've ever looked at a patient's massive list of symptoms, things like syncope, cognitive slowing, systemic fatigue, and felt like they were just being forced into a diagnostic box that didn't quite fit, well, this one's absolutely for you. We're going to break down a compelling case study that shows exactly how a post-viral regulatory failure can perfectly mimic a structural neurodegenerative disease.
Right out of the gate, we've got to contrast two fundamentally different ways of looking at this. On the left, you've got the traditional frame, diagnosing it as a structural seizure or dementia, which immediately sends you down this narrow pathway of anti-epileptics and supportive care. But on the right is the reality of this patient's condition, an integrated multi-system failure. You see, this isn't just one broken structure, it's a 7-layer mechanistic cascade. And the reason this is so absolutely crucial for your clinical practice is simple. If you apply a structural frame to a regulatory failure, you literally close off all the correctable pathways. Shifting your paradigm to this 7-layer model isn't just a neat idea, it's clinically required to actually restore the patient's physiology.
So here is our clinical roadmap for today. First, we'll look at the diagnostic error. Then we'll move to layer 0, the mitochondrial trigger. From there, we trace the neurological cascade, tackle the vascular and immune amplification layers, and finally, present our upstream treatment roadmap. Let's get right into it.
Starting with Section 1, the diagnostic error. We're looking at anosmia and the elusive aura.
Now, what's really fascinating here is a massive, and I mean massive, discrepancy in the patient's chart. The entire seizure diagnosis essentially rested on this single unverified ER intake note that claimed the patient experienced a burnt metal smell before syncope, which, sounds like a classic temporal lobe aura. But the patient explicitly corrected this later on. He said it was just a rather odd smell. Actually, scratch that. It wasn't just a minor semantic difference. This was the entire foundation of the epileptic frame, and it was built on a highly questionable sensory report.
Which brings us to a really critical physiological question. Think about it. Can a patient with a 4-year documented history of post-COVID anosmia even generate a true stereotyped olfactory aura? The answer is a hard no. They physically lack the functional machinery to do that. That odd smell they mentioned wasn't an epileptic aura at all. It was actually a sensory distortion caused by transient cerebral hypoperfusion, so low blood flow, acting on an already damaged central temporal network. Recognizing this completely clears the board, and it allows us to find the actual mechanism at play.
Moving on to Section 2, Layer 0, the mitochondrial trigger. This is the upstream engine of systemic failure.
At layer 0, we're looking at the exact cellular domino effect triggered by SARS-CoV-2. First up, viral proteins disrupt oxidative phosphorylation, or OXPOS, and that creates an immediate ATP energy deficit. Second, this disruption spikes the mitochondrial reactive oxygen species, the mTROS. Third, and this is the really critical part, the PINK1-Parkin mitochondria pathway fails. The body simply cannot clear out these damaged mitochondria. And that leads straight into step 4, chronic activation of the MAVS and NLRP3 inflammasome cascade. So what's the big takeaway here? This self-perpetuating inflammatory loop operates entirely without any ongoing viral presence. The virus is gone, but the cellular engine is stuck in this continuous state of alarm and energy failure.
All right, Section 3, the downstream neurological cascade, covering layers 1 through 3.
So what happens when we translate those cellular mechanisms into concrete clinical science? Well, in layer 1, the viral infection and that layer 0 inflammation force the dopaminergic neurons into senescence. They basically stop making dopamine and just pump out inflammatory cytokines instead, which perfectly explains the patient's Parkinsonian shuffling gait and their cognitive slowing. Then, in layer 2, that lack of dopamine, combined with the mitochondrial ATP deficit we just talked about, hyperpolarizes the thalamus. This locks the brain into a pathological slow-wave oscillation, directly causing the 7 Hz posterior dominant rhythm that showed up on the patient's EEG. It's not structural brain damage, it's an electrical dysrhythmia. Finally, layer 3 is autonomic failure. The incredibly energy-hungry vagal nerve and nucleus tractus solitarius fail, and all that excess mTRO scavenges nitric oxide, totally ruining the vascular tone. The clinical result of all this, an inability to maintain cerebral perfusion, which leads to syncope or transient loss of consciousness.
Next up is Section 4, vascular and immune amplification. We'll look at layers 4 through 7.
Take a look at this specific laboratory fingerprint for the layer 4 vascular pathology. The patient presents with an elevated D-dimer, meaning there's continuous fibrin degradation, but it's paired with a completely suppressed CRP. Now, on a standard panel, you'd look at this and think, wait, where's the inflammation? It looks totally confusing, but under the multi-system failure model, this specific lab pattern is literally the smoking gun for a hidden vascular disaster.
And the main culprit here? Fibrinolytic microclots. These are anomalous amyloid-formed structures that are triggered directly by the viral spike protein. And because they're structurally weird, they completely resist the body's natural clot-busting processes. They physically block up the microcapillaries, which severely reduces oxygen delivery to the tissues. And by the way, that beautifully explains the patient's chronic kidney disease progression. But crucially, they entrap inflammatory molecules right inside their insoluble structure. That is exactly why the CRP was suppressed on our last slide. The inflammation isn't gone, it's just trapped, causing this invisible, chronic microvascular hyperperfusion.
Building on that, let's look at layers 5 and 6. For layer 5, remember how that layer 0 mitochondrial distress activates the NLRP3 inflammasome? Well, that directly primes the mast cells to degranulate, releasing a flood of histamine that causes systemic vasodilation, and that acts as a massive potentiator for the patient's syncope. Meanwhile, layer 6 finally explains that persistent anosmia. It turns out this isn't a nasal issue at all. The autonomic failure creates glymphatic congestion, which traps toxins right in the central olfactory network. Combine that with mitochondrial-driven cell death, and it directly injures the temporal networks. So that right temporal EEG focal slowing and those 4 solid years of anosmia, they're actually the exact same central brain injury, just being picked up by 2 different measurement tools. Crazy, right?
Finally, we hit layer 7, which is all about iatrogenic amplification. Imagine a patient with this incredibly fragile, dysregulated system, and then they're prescribed a triad of medications that essentially act as the final blow. Propranolol blunted his ability to raise his heart rate. Nortriptyline induced orthostatic blood pressure drops, and clonazepam depressed his central nervous system's arousal response to the low blood flow. Put them all together, and this triple autonomic suppression completely wiped out whatever tiny physiological reserve he had left, locking him right into a state of failure.
Which brings us to Section 5, the Upstream First Treatment Roadmap. Time to unlock those correctable targets.
Here is the clinical action plan. As you'll see, every single intervention logically addresses a specific mechanistic layer, starting with removing the biggest roadblocks. We start at layer 7, a careful medication review to safely pull back that iatrogenic autonomic suppression. Then for layer 3, we use autonomic diagnostics, like a tilt table test, to finally confirm the exact syncope mechanism. For layer 5, over-the-counter antihistamines and mast cell stabilizers are used to remove that histamine vasodilation trigger. And crucially, to target the real root cause at layer 0, mitochondrial restoratives like CoQ10 and NMN are deployed to fix the ATP energy deficit and the NAD+ balance. So instead of just playing whack-a-mole and suppressing symptoms, we are systematically rebuilding the patient's regulatory capacity right from the bottom up.
And that leaves us with a pretty profound question to consider for your own practice. Diagnostic accuracy isn't just some procedural preference, right? It's the absolute precondition for recovery. When a patient doesn't fit neatly into a diagnostic box, we have to dig deeper. So how many of your patients who are currently labeled with structural neurological conditions, things like epilepsy, early dementia, or mysterious movement disorders, are actually suffering from an undetected, multi-layer regulatory failure? The tools and the science are out there right now to map these hidden post-viral mechanisms. It's time to reevaluate the terrain, deploy this roadmap, and finally offer these patients a real path back to true physiological restoration.